I was asked to give you a summary of the future of MS. So we'll discuss the role of biomarkers in multiple sclerosis. I review the current approach to the use of disease-modifying therapies. We'll discuss the use of artificial intelligence in multiple sclerosis care, and then at the end, we'll review the concept of neuroplasticity, which leads to other areas like remyelination, repair, and so on and so forth. You're familiar with that already. The relapsing phase of MS early on, as you can see, the density and the frequency of relapses decreases over time, and then the progressive phase of multiple sclerosis. And what is the goal of therapy? Well, we want to decrease, if not eliminate, relapses earlier, and we want to decrease the slope of progression. And is that possible? Well, that's our goal. And now we have a name for that is called NEDA, or No Evidence of Disease Activity, which there are different versions of that. Perhaps the simplest one is what we call NEDA 3. No relapses, no disability progression, and no lesions on MRI. Of course, the more variables we add to this concept of NEDA, in a sense, the more sophisticated we can become in understanding progression that perhaps is under the surface, that has not manifested clinically yet, but that we can actually measure. And that's where the use of things like biomarkers and certain tools on MRI to allow us to understand if there is progression that perhaps is subtle enough that may not reach that clinical threshold that our patients or your providers can notice in clinic. So in terms of markers for acute inflammation, that inflammation that causes relapses, the inflammation that causes lesions, we know that some of those markers can be measured on MRI, and when we do that, we can see those active lesions. But sometimes we can also measure that in blood tests, and there is one in particular that is causing a lot of interest lately called the neurofilament light marker. And NfL has been validated as a marker for acute inflammation, and at times we can actually see that spike of NfL prior to a new acute lesion happening. So it's an interesting area that is now becoming clinically available. We can order those tests, and we can actually look at the amount of NfL and try to use that as a way to measure or sometimes predict acute inflammation happening in the future. Similarly, markers for smoldering or chronic inflammation, that inflammation that causes clinical progression, are a little bit more challenging to measure and to understand. However, when you look at, for example, certain outcomes on MRI, we discussed before brain volume, but also looking at certain lesions. And something that we learn is that not all lesions behave the same way. There is a small proportion of lesions that slowly expand over time. Those slowly enlarging lesions, also known as cells, so SEL, those are lesions that perhaps have a different pathology, and that pathology may represent that chronic smoldering inflammation. So having tools that will allow us to measure those slowly enlarging lesions will be critical, as well as certain blood-based biomarkers like the GFAP that perhaps also may be linked to that chronic inflammatory process. So when you start adding these biomarkers, then you go from that basic NEDA, that is no lesions, no relapses, no progression, to the so-called NEDA plus, that when you start looking at these biomarkers and these MRI tools that we'll discuss. So, but, we are familiar with our medications. We are fortunate that we have a lot of disease-modifying therapies options to choose for our patients. But what are they doing? What are the benefits of these therapies? So for the most part, and I just listed the medications here in no particular order. I try to cluster them by mechanism of action. But what are they doing? Well, they're really good, and to some degree, to affect acute inflammation. They're very good at preventing new lesions, preventing new relapses. To some degree, they may have an effect on progression and atrophy, but their benefit is particularly important early in the course of the disease. And something that we continue to learn is that time is brain. And the earlier we intervene, the better the results are going to provide to our patients. And perhaps you heard about these two different approaches, the escalation approach, meaning starting with something that is not as effective and then move on to more efficacy or higher efficacy as patients continue to progress. Well, that approach perhaps was popular back in the 90s. Now it's becoming less desirable. And that's why most of us will prefer to have more of an early intensive approach in which we hit hard early on with highly effective therapies, trying to address that acute inflammation that we know that is going to be maximal at onset. So there are different studies that has been published. This published study came from the Swedish registry, and they looked at the onset of medications, so-called highly effective therapies, that you can see that in blue, versus the low, starting highly effective therapies late in the course of the disease. And this study actually looked at the gap of 2 years. So in blue, you can see patients that started highly effective therapies at early as diagnosis, and you can see that the benefits in terms of progression was substantially lower than the patients who actually delay onset of highly effective therapies. They have higher amount of disability progression. So you can see a clear benefit in starting highly effective therapies earlier, and that is a difference of 2 years. A study done in Norway looked at patients who actually started highly effective therapies as their first drug, second drug, or third drug, and they measure the likelihood of achieving NIDA. And you can also see that patients who actually started disease-modifying therapies of high efficacy as their first drug had a 68% chance of NIDA. If that was started as a second drug, dropped to 66%, and patients who started highly effective therapies as their third drug dropped to 53%. So all of these studies are telling us the same story, that if you use highly effective therapies as early as possible, the benefits are going to be higher. So there are two current studies that actually are trying to truly prove evidence to that. One is done in between the UK and the US, called the LIVER study, and the other one is done at the US, that is a randomized study looking at highly effective therapies compared to low efficacy therapies. All right, so moving on to the next topic, the use of artificial intelligence in multiple sclerosis. Perhaps you've read in the news, AI being used for everything in life now. So of course, we need to also be educated on AI use in MS. And perhaps the most critical area is in imaging. So here I have a picture of you showing the different evolution of lesions. So this will be what a typical acute lesion is. You have all these blue dots being the immune cells getting into the brain. In green and red, you can see the axons and the myelin. So after that acute lesion resolves, some lesions will still have some active inflammatory cells in the periphery of the lesions. So these inflammatory cells, we call them microglial cells, are thought to be the ones that cause this slow expansion of lesions. And that chronic inflammation can last up to 7 years, in which then a lesion becomes chronically inactive. So there is a lot of interest in trying to truly capture those slowly enlarging lesions as a way to understand that chronic process of inflammation that happens in the brain. So it's very difficult and challenging to truly look at those slowly enlarging lesions with a naked eye. So that's where AI may be a wonderful tool to measure the volume of lesions, and in longitudinal MRIs be able to say, okay, this lesion is growing. So that there are different tools that we can use. At Rush, we are finalizing, hopefully soon, a contract with Icometrics, being able to offer that as a tool to our patients. And this is an example of how those reports are going to look like, in which you can see that difference between the volume of lesions before and after, and truly capture those lesions that actually are slowly enlarging or expanding. This is an example of how that platform will look like. Will give us an idea of the number of lesions, but most importantly, the volume of lesions over time, as well as we can also measure brain volume. We can be able to then look at the amount of brain, the cortical brain volume, the subcortical brain volume, compare that to a normative healthy control range. So we can know there is certain percentile of loss compared to healthy aging. But most importantly, longitudinally, we can also assess for change in brain volume over time. So this is a classic example of how AI applied to imaging can help us understand a little bit more than just, are there any new lesions? But we can now start looking at, are any lesions slowly growing? What is happening with brain volume over time? So we can actually get a little bit more nuanced in helping our patients. There's also an app that comes with this program called the iCompanion app, that patients can input information on their symptoms, quality of life in between visits. So we can actually improve the ability to capture symptomatology and quality of life questionnaires. I believe they are also testing a way to measure processing speed through certain games that patients actually can complete. Again, going back to cognition. If we measure cognition after you came to the visit and you had to park and perhaps walk, to the visit, you're stressed and you're tired, and then we measure processing speed, may not be the right context for us to get an idea of how your brain is working. But if you do it in your house and you're rested and your stress level perhaps is lower, maybe the most representative measurement of your cognition. So I think there is a lot of value in measuring these tests outside of the busy clinic environment. So another perhaps interesting and exciting development is in the area of serum-based biomarkers. There is a platform called Octave that allow us to have access to a total of 18 different biomarkers. So this is just a blood test. And those biomarkers have been validated in understanding different processes in multiple sclerosis. And I like this slide because it reminds us of the different thresholds that we have to capture what is happening in someone with multiple sclerosis. So here on the top, you have the clinical threshold. Those are your relapses, right? We know that when someone had a relapse, there's been ongoing inflammation that has been brewing prior to that relapse. There has been inflammatory markers on blood, and perhaps it's been even MRI changes before that lesion caused symptoms. So if we are only waiting to look at relapses as a way to know if your MS is stable or not, we may be missing a lot of activity that is happening under that surface. So MRI here in the middle is helping us to look at lesions. Some of those lesions, as we discussed before, may be asymptomatic, not causing symptoms earlier. So when we do MRIs, we can capture some of that pathology that perhaps is not causing symptoms. But the exciting part of blood tests is that with certain biomarkers, we can capture inflammation that is happening prior to that inflammation causing lesions. So I think the deeper we dive, the more sensitive we can become in truly understanding what is happening in the background. So this tool will give us a total inflammation score or disease activity score, and that score is a result of levels of 18 different biomarkers. So that gives us a sense of how much inflammation is happening behind the scenes, and we can use that score in a longitudinal way to understand what is happening. Is there any concerns of perhaps inflammation in the future? This is an example of and the name of all the different biomarkers. They have been grouped into different processes, whether they represent, myelin biology or neuroaxonal integrity, neuroinflammation. So we can start understanding, what process may be happening behind the scenes. So very exciting. We can offer this test now. I believe Blue Cross is being actively negotiating to be able to cover that. So I don't want to promise anything, but I think we might hear good news that might be covered by insurance. If it is not covered by insurance, I know the company offers a sliding scale of cost that I believe the highest someone can pay is $150, I believe, for the test. For Medicare, there is no additional cost. So this is something that is very exciting to be able to offer in our clinic. Yes, sir. Right. How do you take it back to your practitioner? Uh, that's a good question. So I believe that empowering patient with information is the first step, because that might trigger that conversation back with your yeah, I think that's a great question. So moving on, I believe this is the last few slides. So I want you to leave today also with knowledge on plasticity. And before I jump there, earlier I asked you to raise your hand if you were familiar with brain reserve. Now I'm going to ask you the same thing. Raise your hand if you're familiar with neuroplasticity. Okay, I like that. I like that. So, but still, there is a lot of room for improvement. So let's do the exercise at the end, and hopefully that improves. So, what is plasticity? So, it's the ability of the nervous system to change its activity in response to intrinsic or extrinsic stimulation. Basically, the ability of the brain to adapt to things that come from outside or things that we do from inside our body. There are different mechanisms. One is what we call neuronal regeneration or collateral sprouting. The other one is functional reorganization. But I realize that these are very heavy terms. So what I thought to do today to you is make it simple so we can all understand and apply. And for a moment, I want you to think that your brain is like a big company, and each cell or each neuron is like an employee. So let's imagine that your brain is like a law firm, and your brain has 300 employees, and everyone is working well, and everyone was doing great, and then COVID hit, and that company had to reduce their workforce. And all of a sudden, from 300 employees, it went to 200 employees. So imagine now that the brain was doing great, and then MS hit, and it caused some atrophy. And you went from having X number of cells to a reduced number of cells. So what are the things that that law firm is going to do? All of a sudden you have 300 employees and you went to 200. How can you make that law firm continue to function despite having less people? Just give me ideas, examples. Make them work harder. And we talked about that before with MS, right? We saw functional MRIs that those neurons were working harder, right? What else? I'm sorry? Let somebody go. Yes, they did already. They went from 300 now to 200. So how do you make these 200 employees that are now in the workforce do the same thing and function at the same level? Give them more roles of responsibilities. Excellent. Train them. Very good. Give them more money, more motivation. Excellent. How about create more employees, right? So use more tools or bring more employees to the table. That's what the brain is doing. The first thing the brain is going to try to do is create more neurons. If I have a reduction number of neurons, can we build more neurons? That's something we call neurogenesis. We kind of talked about that before. There are certain parts of the brain that can be induced neurogenesis. Not every part of the central nervous system, but particularly those memory cells in the hippocampus that you can stimulate that. So one of the things we know is in MS, the use of exercise, particularly exercise, is one of the most profound ways to improve neurogenesis. But also mindfulness, meditation, those are ways actually have been proven to improve neurogenesis and help consolidate more memories. So those are different things that actually are showing a benefit in neurogenesis. But let's go back to the example. So you went from 300 employees to 200 employees. Well, somebody says, train them, improve efficiency. So improve communication with the current employees. So you can't bring more people. You have to function with the 200 employees. So let's make that communication more efficient. And the brain is doing the same thing, and that's what we call synaptic plasticity. So in multiple sclerosis, if you train those cells to be more efficient, you can take advantage of this mechanism that everyone has, and MS is not taken away from you. So let's review how neurons talk. So here we have one neuron, axon, dendrites, talks to the next neuron. In MS, what could happen is that lesion interrupts the communication between these two neurons. So two things can happen. One is what we call compensatory sprouting. What that means is that this cell now has to communicate with this cell that has that interruption from the previous neuron. The other one that could happen is regeneration. You can regenerate that pathway between the two. So it's been proven in multiple sclerosis that synaptic plasticity can be positively influenced by exercise, environment, repetition, motivation, and neuromodulation. And this brings us to Physiology 101. So today you're learning about anatomy, you're learning about neurology, and now you're going to learn about physiology. So going back to how the two neurons talk. So in the middle, that's your normal synapse. You have one neuron talking to the next neuron. They send these neurotransmitters, and they're going to affect the next neuron by entering through this channel. That's normal. That happens to all of us. And imagine that this is happening when we exercise. So as I'm walking, this neuron talks to the next one by sending these neurotransmitters. But let's say I want to run, and I want to exercise, and I want to improve that function over and over and over, and I want to challenge the system. So all of a sudden, you're going to find that in this synaptic cleft, the amount of neurotransmitters is going to increase because the density and the amount of activity is increasing. Are you following me? Okay. So what do you think is going to happen to this neuron? All of a sudden, you have more chemicals coming to your door. What do you need to do? You need to open more doors so they can get in, right? So what is going to happen is that the amount of receptors is going to increase. So one of the normal compensatory mechanisms that we have in the brain to respond to increased activity is an upregulation of the receptors in the postsynaptic neuron. So when we are exercising and we are getting better at something, we are actually making changes in the postsynaptic neuron to increase the amount of receptors to be able to tolerate that extra amount of exercise and activity in the neurons. Conversely, have you heard the word, if you don't use it, you lose it? Okay, well, if you don't use it, you lose it is the way to explain what we call long-term depression. Meaning, if you don't use certain pathways, these neurons are going to say, hey, I haven't had this chemical stimulation for a long time. I'm going to become lazy, and I'm going to downregulate my receptors. I don't need them. So if you don't use certain functions, the neurons, those pathways in the brain, are going to say, well, maybe if they don't use them, that means that they don't need it. I'm going to just rewire and do something else. So this explains how this system is constantly being influenced by what we choose to do. And the things that we do more, the system is going to get better. And this process does not get affected by your multiple sclerosis. So what I'm trying to say is that if you have a function that you want to improve, you need to do it. You need to use it, and you need to challenge that function. And if you don't know how to do that, that's when you ask for help. Whether it's a physical therapist, if that function includes movement, whether it's an occupational therapist or a neuropsychologist, if that function involves cognitive skills. And the last example I have for you is that going back to the law firm, you have now 200 employees. You need to reorganize them. You need to retrain them. And that's what we call functional recovery. And that's something that perhaps you're familiar with. And we know that through physical therapy, rehabilitation, but things that perhaps you haven't heard before, mindfulness and meditation is related to long-lasting changes in hippocampal functional topology in resting state. And that was a study done in multiple sclerosis. And last but not least, musical training, neuroplasticity, and cognition is a great article that look at how through music therapy you can reorganize and retrain those neurons in the brain. So I believe I have a few more minutes left. Talk about remyelination. Nothing new. We are still trying to find that medication that will help us remyelinate. Some of the positive trials are listed here in neuroprotection. More to come in terms of simvastatin. There are a few studies done in the UK and in the US to try to see if high-dose simvastatin can be helpful for neuroprotection. We heard about BTK inhibitors. The first clinical trial, unfortunately, did not show any beneficial effects compared to teriflunomide. There are a few other studies on the BTK area. I've just listed them all here. that we are waiting to see if there is any benefit. If you're not familiar with BTK, that's a different way to affect B cells, but also theoretically has an effect in microglial cells that are those cells in the CNS, in the brain, that are perhaps helping to expand those slowly enlarging lesions. So a lot of interesting science behind BTK inhibitors. Unfortunately, the first study did not show any significant benefit, but I think we are all hopeful and still have some cautious optimism for perhaps the other medications that are currently being tested. And there is always a question about stem cells. So this is just to give you a summary of the research that has been published, data on autologous stem cell transplantation. And you can see that some have shown some beneficial effects when it comes to proportion of NIDA. The errors in the confidence interval is pretty wide. So nothing has shown so far to be better than what we currently have available, but there are some studies that actually are looking into that. I just listed these two studies, one in the UK, one in the US, that are currently looking at autologous stem cell transplantation in patients with multiple sclerosis. And with that, I would like to end. Thank you for your attention.
Thank you again. I have one online question, and then we'll go to our audience here. I'm going to come back there in 1 second. Okay. I'm trying to interpret this question. She or he were talking about the brain reserves, and do lesions in the spinal cord also affect brain reserves?
That's a great question. So the spinal cord is a place where all the pathways to and from the brain will converge. So there is little, if any, brain reserve, as to speak. The brain reserve, by definition, is in the brain, not in the spinal cord. However, there might be some room for compensation that could happen even with spinal cord lesions. So if you look at the amount of redundancy and reserve, the place that has maximal reserve is what we call the supratentorial part of the brain, meaning the upper part of the brain. As you get closer to the brainstem and the spinal cord, the amount of reserve decreases. That doesn't mean necessarily that it's not possible to recover from lesions in the spinal cord.
Hi. I actually have been on Crevas for about 5-6 years, and I'm just wondering, I didn't see anything about that. Is it actually helping me?
So, I didn't go there for a particular reason, right? So it's very difficult to make statements that apply to one patient in large group. However, what I can answer to that question is ocrelizumab, and now we have different type of anti-B cell therapies. They have proven efficacy in markers of acute inflammation, in relapses, in lesions, as well as progression. So we usually use this data from large phase 3 trials to establish a sense of, how good are these medications, right? So it's considered one of those highly effective therapies, and that's based on clinical trial data. Why it's not helping you, that's something I can't answer here. But I will say, I think something that important that comes from that question is all of you need to have an honest discussion with your provider every time you see them, saying, how do I know this medication is helping? How can I measure that? And if there are any areas that you feel are not being addressed, address them during the visit.
If a patient can reverse the neurological reserve, does that mean that you can reverse disability as well?
So no, right? So it's not linear. So yes, you can stimulate reserve by all the things that we talked today. Is that necessarily going to translate that for improved function? Not necessarily. We hoped yes. And there are certain functions that may be easier to restore. But unfortunately, there's also circumstances in which function has been lost, and there are some strategies may not help to restore that function. However, the idea of introducing lifestyle interventions to promote helping brain reserve has the intention to make the brain as healthy as possible, as resilient as possible, and as prepared as possible to compensate for any future pathological insult. Yes. Absolutely.
Can
That's a
you
great
repeat
point.
what she just
Yeah,
said,
so
please?
that's a great point. So basically, what she's saying is that we are also aging, right? So engaging into these lifestyle interventions is going to help us age in a healthier way. And to your point, I think, particularly if you have a disease that you know that is affecting the brain, well, do everything you can to make the brain the healthier you can, so you're better prepared. And that can also help you function in life the way you want. So sometimes functional recovery, it's not possible, but that doesn't mean that these interventions are not helpful.
Thank you again for a fabulous presentation. We appreciate you and your time. Thank you.
Thank you.